webinar. Please note we have reserved time at the end of the webinar to address questions, but we encourage that you submit your questions as they arise. And we ask that when you submit a question, please be sure to submit it to all panelists as shown on this slide, and specify if the question is for one of the three panelists, and include your name and organization along with your question. You can also use the chat panel to interact with your fellow participants, or you can also use it to let us know if you're experiencing any technical difficulties. If you do have technical difficulties, use the send to box in the chat panel to send your message to us, all panelists, and we'll do our best to help you. Please note that this webinar is being recorded and will be available soon afterwards on the HFG website. And with those logistics out of the way, let's begin. To get started and to get a little bit of our audience participation in, we wanted to pose an important question. And that question is, whose job is it to ensure that data are used to inform policy? For those of you that are on your computer, you should now see a pop-up on the right side of your screen where you can select the answer to that question. The possible answers are A, the technician producing the data, B, the policymaker requesting the data, C, whoever is funding the data, or D, everyone, all stakeholders. So I'm going to give you a minute now. We're asking that each of you to select your response to this question. And once you've selected your response, please make sure you scroll down and click the submit button so that we can receive your answers. And I'm just going to pause a minute and give everyone a chance to respond, and then we'll look at the results. Okay, so we're going to, hopefully you've submitted your response. We're going to wrap up the poll now. Okay, so it looks like the results have come in. It looks like this audience is heavily skewed towards all stakeholders, so 44% of you think everyone is responsible for ensuring data to be used. 2% of you think it's the technician producing the data, and 3% of you think it's the decision maker requesting the data. So a very clear trend in this group. So thank you all for participating. Keep this question in mind because we will circle back to it throughout the webinar and at the end. All right, so I think we all know that decision makers have access to many different types of data, and the focus of our webinar today is around using health spending information in particular to inform policy and planning decisions. Before we meet the panelists, I wanted to just take a minute and provide a little bit of background on this topic so that we're all kind of coming to the discussion on the same page. So first off, what do we mean when we say health expenditure data? And to answer that question, I'm going to zoom out briefly and say that there are many different types of health financing information, which you can see represented here on this slide. So there's health accounts, there's insurance claims data, there's tax administration data, there's efficiency studies, all of these different types of health financing information. But for today's webinar, we're focusing in on a subset of this health financing information to focus on health spending data. And we've tried to bold the sort of top half of this list, which represents health spending data. So health spending data may capture total health spending in a country through a health account study, or health spending data may look at expenditure on a specific disease area, like through the National AIDS Spending Assessments, or health spending data could focus on specific sources of data, so through a public expenditure review, from insurance data, or through household consumption surveys. So this is just to give you a background on the types of data that we're talking about today. One thing you'll hear as a theme running through each of the panelists is that it's never one single piece of data that leads to policy impact, but it's really a combination of many different pieces of data, of which health spending is one piece, that are needed to inform policy. The second brief bit of background information I wanted to raise is sort of this question of what do we mean when we talk about policy use or decision making. And for the purpose of this webinar, we are interpreting decision-making quite broadly, everything from decisions about the day-to-day management of government resources all the way up to very high-level decisions about health financing policy and strategy. And then the final bit of background I wanted to share is just this idea of why is health spending data important and why are we devoting a whole webinar to this topic. And this diagram here points out 3 key areas where health spending data plays a critical role in decision making. The first is that the health spending data is important to help diagnose or identify challenges in the health system. So for example, spending data can highlight maybe skewed spending in your country where health spending is heavily weighted towards high-level tertiary care, and there's very little investment in primary care services. And so that information provides a useful background as you're going into making decisions. The second key area where health spending data is important is that it provides evidence to justify reforms. So the data can help policymakers understand the costs and impacts of different reforms that could be implemented and allows them to sort of model out that impact and identify the best option that suits their country's needs. And then finally, health spending data can help monitor health system changes and readjustments and can monitor reforms to make sure that they're meeting their intended objectives. And so these 3 components lead to more transparent and informed health financing decisions. And just to give an example of how health spending data can be used, this map shows the results of a study the HFG project did, looking specifically at how health accounts data have impacted policy. And this is a summary of our findings where we've identified over 30 countries with more than 60 policy impact stories. And so this map gives you a snapshot of how these countries have used the health accounts data to better raise funding for health, to better manage their existing funds for health, and to better use the health funding to purchase priority health services. For more details and to see each of these country examples, you can visit the HFG website, which is at the bottom of this slide. And I'll just point out, this is a specific example to health accounts, so it's not all of the spending data that we're talking about today, but it's just to illustrate how this data can be used. Now that we've set the stage, let's jump into the panel discussion and hear how countries have been able to do this. I would like to introduce our first panelist, Mr. Simon Nassa. Mr. Nassa is an economist at the Ministry of Health in Burkina Faso with the Department of Planning and Monitoring. He works on the development of Burkina Faso's health accounts and is also part of the technical team producing the National AIDS Spending Assessment. He is also a consultant for the World Health Organization, assisting other countries in the development of their health accounts, and he has extensive experience in using health accounts to drive policy change. Nassa will be presenting in French, and my colleague Krishma will provide a translation of his key points in English after he's done speaking. The story that Nassa has to share is quite powerful, and so if you speak French, you're in luck. If you don't, please bear with us. This format is a bit of an experiment for us, so we're trying something new here, but we really think this story is powerful and want it to be shared with this audience. So with that, without much further ado, Nassa, thank you for joining us today. I wanted to jump right in and ask you, how has Burkina Faso used health expenditure data to influence policy?
Bonjour, Monsieur Nassa. La question qui a été posée, c'est le Burkina Faso, comment a-t-il utilisé les données de dépenses de la santé pour la prise de décision politique?
OK. Au Burkina Faso, je vais donner 3 exemples de l'utilisation des données des comptes qui ont influencé les politiques. Premièrement, les comptes permettent d'éclairer la planification du secteur de la santé. Deuxièmement, les comptes permettent d'orienter la mise en commun des fonds dans le cadre de l'assurance maladie. Troisièmement, les comptes fournissent des évidences pour les allocations budgétaires. Pour le premier point, il faut dire que les comptes informent régulièrement les principaux documents de politique du gouvernement. Au nombre de ces documents, on peut citer le cadre de dépenses à moyen terme pour les ressources de santé, le plan stratégique du secteur de la santé, le plan stratégique national de financement pour informer la couverture sanitaire universelle. Pour le second point, il faut dire que les comptes assurent une protection financière grâce à la mise en commun des fonds, en ce sens que les comptes servent de base factuelle pour fournir des évidences dans la mise en œuvre de la politique de gratuité des soins en 2016, mais aussi pour le suivi de cette politique de gratuité. Il faut dire qu'en 2016, le gouvernement a mis en place une politique de gratuité des soins qui fournit en fait des soins aux enfants de moins de 5 ans et aux femmes enceintes gratuitement. Alors, donc les comptes donnent la structure des dépenses des ménages par rapport aux médicaments à l'équipe qui suit en fait cette politique-là. Les comptes éclairent aussi les politiques de suivi de l'assurance, en ce sens que le bureau qui dirige le mécanisme de l'assurance réfère régulièrement à l'équipe des comptes chaque année pour suivre la structure des dépenses, notamment le poids des dépenses des ménages en médicaments. Et enfin, les comptes permettent de faire l'allocation budgétaire pour la santé. En ce sens qu'initialement, le budget de la santé était réparti selon les régions sans données clés. Alors, depuis l'avènement des comptes, alors le bureau se réfère régulièrement aux données des comptes pour répartir les dépenses suivant les évidences. Je vous remercie.
Merci, Mr. Nasser. So I will summarize what Mr. Nasser explained. In Burkina Faso, they have used health accounts data and health spending data in 3 key ways. The first is to inform health system planning broadly. Health expenditure data has contributed to the midterm expenditure framework for health, the health strategic plan, and also the strategic plan on financing UHC. Secondly, results from health spending studies have informed and led to the design of mechanisms to increase financial protection for households. For example, this type of data was used or provided the evidence to introduce free health care for pregnant women and children under 5 in 2016. And they are also using this data to monitor whether this mechanism of free health care is helping to reduce household out-of-pocket spending, especially for drugs. And the third way in which health expenditure data has been used is to inform or provide evidence for annual health sector budget allocations. So health expenditure data helps to show where money is being spent and what for, and so this has helped to allocate budgets to regions based on needs rather than historical allocations.
Wow, thank you. That's quite the wealth of examples of policy use. Nasa, can you talk about some of the factors that led to the use of health accounts in Burkina?
Oui.
Monsieur Nassa, que sont les facteurs qui ont contribué à l'utilisation des données des dépenses de santé?
Oui, allô?
Oui, Monsieur Nassa, que sont les facteurs qui ont contribué à l'utilisation des données de santé?
OK. Au nombre des facteurs ayant influencé l'utilisation des comptes pour orienter les politiques, on peut citer 3 facteurs. Premièrement, les facteurs se résument à l'institutionnalisation des comptes. En effet, il faut la régularité dans la production des comptes. Au Burkina, les comptes sont produits depuis 2005 et les rapports de 2005 à 2016 sont disponibles, ce qui permet aux parties prenantes de les intégrer dans leur cycle de planification. Deuxièmement, nous avons une rencontre régulière avec les parties prenantes où les données des comptes sont discutées afin de prendre en compte les attentes en fait, de ces différentes parties prenantes. Le deuxième facteur, c'est la disponibilité des données produites qui est de haute qualité. En effet, l'équipe technique du Burkina Faso dispose d'un personnel fort et multidisciplinaire et un comité de pilotage permanent. Ces équipes sont établies à travers des textes législatifs. L'équipe apporte même de l'assistance technique à d'autres pays. Donc, ces facteurs conduisent à la production et à la diffusion régulière des résultats de haute qualité en temps qui sont acceptés par les principaux intervenants. Alors, le troisième facteur, c'est la bonne dissémination des résultats. Nous avons au Burkina Faso la rencontre annuelle, qui est une culture d'usage où les données sont partagées de manière proactive avec les parties prenantes. Et à l'occasion de cette rencontre, les lettres sont envoyées aux principaux intervenants avec des rapports sommaires, avec aussi des dépliants et des mémoires. Donc, nous avons aussi les rapports des données qui sont disponibles sur le site web du ministère de la Santé, sur le site de l'Institut de la Statistique et puis sur le site de l'OMS. Et nous avons aussi l'existence d'un service, c'est-à-dire le service de réponse rapide, qui prend le temps de résumer en fait, les principaux indicateurs pour les décideurs. Donc, l'équipe, ce service-là, prend l'initiative de faciliter le travail des décideurs. Donc, voici les facteurs qu'on peut résumer pour montrer l'utilisation en fait, des comptes pour orienter les politiques. Je vous remercie.
Merci. Mr. Nasser provided 3 factors that have contributed to use of health expenditure data. The first is that health accounts in Burkina Faso is institutionalized, meaning that since 2005 there is regular production of health accounts. And so data from 2005 to 2016 is available for decision makers. And so this has helped stakeholders to know this and expect data to be available. The second is the availability of high-quality data. There is a technical team with high technical capacity and a permanent steering committee that are written into legislation. And these teams are available to produce health accounts every year. And the third factor is dissemination. So the health accounts team regularly meets with stakeholders and disseminates data in a very proactive manner. Data is shared in advance with decision makers through brochures, short briefs. Data is also available through the Ministry of Health website, Statistics Institute website, and also the WHO website. And finally, there is a rapid response unit in the Ministry of Health, and they respond to specific questions from policymakers on a timely basis, and they provide analysis that respond directly to questions as they come up.
Thank you. And Nasa, my final question, I know that you've supported the health accounts in Burkina and are also supporting other countries. Based on your experience with this support, could you make recommendations on how to increase the likelihood that data gets used for decision making?
Monsieur Nasser, vous avez d'expérience dans les autres pays aussi. Que sont vos recommandations pour d'autres pays afin d'assurer l'utilisation des données de dépenses?
OK. Afin d'assurer l'utilisation des données des dépenses, je suggère 2 types de recommandations, avant l'élaboration des comptes et après l'élaboration des comptes. Alors, avant l'élaboration des comptes, je suggère que les pays disposent ou recrutent un personnel qualifié qui doit régulièrement travailler afin de disposer des données à temps, de haute qualité, des données qui sont acceptées par tous. Et je suggère aussi que le pays tienne une rencontre avec l'ensemble des acteurs afin de prendre en compte leurs priorités dans le rapport. Je suggère aussi que le pays produise les données à temps afin qu'elles soient intégrées dans les différentes planifications et documents stratégiques. Alors, après l'élaboration des comptes, je suggère que les ateliers avec les principales parties prenantes soient faits. C'est-à-dire que les pays fassent des présentations ciblées, c'est-à-dire une présentation vers les bailleurs de fonds, une présentation vers les ONG, une présentation vers le ministère de l'économie et des finances. Alors, je suggère que le pays rende disponibles les résultats à travers des ateliers de dissémination, à travers la mise en ligne de ces données-là, et puis à travers des supports qui soient accessibles et sans frais. Alors, de mon expérience, j'ai appuyé un certain nombre de pays dans l'élaboration des comptes, notamment le Mali et puis la Côte d'Ivoire. Alors, en Côte d'Ivoire, par exemple, les partenaires sont impliqués dans l'élaboration de la thématique des notes de politique, les policy briefs, et cela rentre dans la promotion des résultats. Donc, lors de l'élaboration des policy briefs, tous les représentants des programmes sont réunis et un thème est dégagé et un plan aussi est dégagé et les discussions s'engagent et puis les données convergent vers le besoin en fait, des utilisateurs. Au Mali aussi, où j'ai participé, alors à ce niveau, les résultats sont présentés et discutés à une réunion qu'on appelle la table ronde des bailleurs. Donc, au cours de cette réunion, tous les bailleurs sont présents et les résultats sont présentés. Alors, et à la fin, il y a un résumé qui est fait et puis il y a les principaux indicateurs qui sont dégagés et puis qui sont présentés à tous. Alors, en plus de ces deux exemples-là, au Burkina Faso ici, on peut citer par exemple l'existence d'un service, c'est-à-dire le service de réponse rapide, qui facilite le travail des décideurs, alors en synthétisant les principaux résultats pour les bailleurs. Donc, voici les suggestions que je peux faire pour amener l'utilisation des comptes par les pays. Merci.
Merci, Mr. So, in terms of building a culture of use, Mr. Nasser mentioned that it's very important to think about factors before starting a health expenditure study and after. So before starting a health expenditure study, it's really important to commit to a team with high technical capacity and who are available, who have time to produce this data on a regular basis. In addition, it's important before starting data collection and production to meet with key stakeholders to understand what their priorities are. And also, health expenditure studies should be planned so that, and they should be integrated into the planning process for the health sector so that the results are published in time when key decisions will be made. In terms of after health expenditure data has been produced, Mr. Nasser talked about the importance of dissemination. So tailoring dissemination to different groups such as donors, NGOs, Ministry of Economy and Finance. It's important to make the data easily available to these stakeholders. In Côte d'Ivoire, their stakeholders meet together before a health account study, and they discuss the key challenges or policy questions in the health sector and converge to one theme that they would like to develop a policy brief for. And so the technical team, when they finish the health expenditure study, they can tailor their analysis to that policy theme that was identified at the beginning. In Mali, there is a similar discussion amongst stakeholders. There is a roundtable that meets to discuss again the key challenges, and they define a key set of health indicators, health financing indicators that they would like to measure. And so again, the analysis is tailored to those indicators. And in Burkina Faso, Mr. Nasser mentioned the Rapid Response Unit. Again, this unit that is available to respond to policy questions as they come up.
Thank you, Nasa. I'm really struck by the wealth of examples that Burkina Faso has around using this data. And as we talk with the other panelists, we'll be hearing from several different perspectives today. As a member of the technical team producing the data, Nasa brings more of a technical perspective to this discussion. And I think the two themes that really stood out to me in hearing him speak was first this idea of creating a culture of use. Burkina sounds like they really have an environment where data is valued, expected, and used. And then the second idea of taking the onus off of the policymaker, and he talked about how the technical team through the Rapid Response Unit is fully responsive to tailored policymaker needs, really compiling the data and responding to individual questions on a real-time basis. So thank you for that. A brief reminder, if you have questions for NASA, please submit your questions in the Q&A window now, and we'll save them for the end. I'd now like to move right along and introduce our second panelist, Dr. Selby. A medical doctor by profession, Dr. Selby worked as a medical officer in Ghana and in the UK prior to taking the appointment at the National Health Insurance Authority. She is currently the Deputy Chief Executive of Operations, and she has 10 years experience, including 4 years each, as the Director of Clinical Audits and the Director of Claims Management. She has played an integral part in the development of the diagnosis-related group payment mechanism, the development of the accreditation tools and process, and the introduction of clinical audits and the introduction of e-claims. Dr. Selby is also on the steering group for the Joint Learning Network. Lydia, it's a pleasure to speak with you today. Thank you for joining us. Let me jump right in and ask you, how has Ghana's National Health Insurance Authority used health spending data to influence policy?
Thank you and welcome to all participants. Ghana has had its national health insurance running for about 13 years now. And in the latter few years when we really started collecting our claims data, which showed pattern of use, we began to see certain trends that made us sit up. everybody knows that Ghana's prices of medicines are quite high, but it's when we really started analyzing the prescribing patterns and the cost to the health insurance of medicines, which in Ghana are paid fee-for-service, that the country decided we needed to really do something about it. And by analyzing the price build-up and all that with the help of WHO and using some analytical tools from the JLN about triggers that need action, we all realized that we could, by removing some of the VAT on medicines and medicines imports, actually achieve a 30% reduction in the cost of medicines to Ghanaians. And so that work has now been done, and the new medicines price list is going to be coming out within the next week, which guarantees a 30% reduction across the board, which obviously is going to help the health insurance a great deal. It has allowed us to negotiate lower prices with manufacturers and distributors. So a lot of policies, I mean, we were able to persuade the Ministry of Finance to take the VAT off medicines because we could show clearly what the impact will be. So this is a great move for us. Another thing was using financial implications to force or enforce compliance around who is allowed to prescribe which drug. Once the health insurance came, people were not paying out of pocket. It became almost a free-for-all. And even though we talked about safety, people didn't listen too much, but we showed the financial implications of non-enforcement of our drug policy. Then everybody, all the stakeholders got in. And so the financial data is making a bit of an impact really on us around medicines policy and safety.
Thank you, Lydia. That's quite a powerful example. Can you delve into some of the factors that led to the use of that data to change policy?
I think, first of all, the accuracy of the data. We were collecting it regularly. It was institutionalized. I mean, we all had access to it. It was transparent. So although we'd all talked about medicine prices are high in Ghana, until we were regularly analyzing the data, there was no real impetus to do anything about it. I think also it allowed us to really convince the lawmakers, the policymakers, the Ministry of Finance that, you know, this data, if you look at it clearly, if you remove the VAT policy, pass this law, whatever, we can make a big difference. And the timing was crucial because we've just had elections about a year ago. So you had a new government in place and you can kind of make your advocacy case. So I think it's transparency, accuracy, and right timing in this particular situation that got the changes made. Thank you.
Thanks, Lydia. Based on your wealth of experience in this area, what recommendations would you make to our listeners in other countries about how to increase the likelihood that financial data gets used for decision making?
First of all, those who are looking at the data must be convinced that the data is reliable. I think you have a better impact on the decision makers or the policy makers if the data is institutionalized, because then it's continuous, it can be reproduced at any time, as opposed to one-off surveys. So if you're keeping good health data accounts, then anybody can do the same analysis and kind of come to the same conclusions. So it's more likely that policymakers will take actions on it. I think it should be aligned to your key strategic objectives. Sometimes we do surveys of financial data that kind of don't have critical meaning at the time, and so it ends up on the shelf. It's nice to know, but I don't have time to look at it. Whereas if you're continuously collecting data, have dashboards, you have your triggers, then it's easier to convince a decision maker, especially if it's a major policy change. When they can see the trends, the tracks, the triggers, it's easier to do. And I think sometimes the technocrats or technicians don't use language that policymakers understand, especially in the health arena. The people making the decisions tend to be finance people, and everybody knows health is good. But if you don't translate the financial data into language that they readily understand and the impact in a more visual way, then sometimes your data gets ignored. So I think these are some factors that can make the likelihood of your data being used more likely. Thank you.
Great. And so Lydia comes from a slightly different perspective, more of the user side of the health financing data, but I'm struck by a similar theme that we've heard echoed by NASA as well, sort of this idea that data from one-off research studies may be more likely to sit on the shelf. It's important that there's this culture of use where there's regularly produced data that people know and trust and that's available, and that sort of institutionalized level of data is difficult to just ignore or dismiss, and creates a level of trust that can be more likely to lead to this culture of use. So thank you. Before we move on, just a quick reminder, if you have questions for Lydia, please submit your questions in the Q&A window now. We'll compile them and address them at the end. I'd now like to introduce our final panelist, Krishma Bhuwani. Krishma serves as a resource tracking advisor for USAID's Health Finance and Governance Project. She has over 11 years experience in health financing and international development, with expertise in resource tracking, performance-based financing, and public financial management for health. Previously, Krishma worked as an economist in the Burundi Ministry of Health under the DFID-funded ODI Fellowship Program. She holds a master's in international development from the London School of Economics and a bachelor's in economics and management from the University of Oxford. Krishma, welcome. Given your global experience on the HFG project, have you seen other country examples of using health expenditure data to inform policy?
Yes, we've definitely seen more examples on the HFG project. I'd like to share 3 of them with you today. The first is in the Eastern Caribbean. In that region, the countries wanted to develop a case for why donors should continue to invest in the HIV/AIDS response. And so the HFG project worked with these countries to design and develop an investment case. And I think a key success factor here was that the entire process was really country-owned. The countries had a clear idea about what they wanted to achieve and what type of analysis was needed to achieve that objective. And this strong ownership ensured that the investment case really met their needs, and the governments ended up using the results in discussions with potential donors. And this led to a $5 million grant from the Global Fund. We also have an interesting example from Egypt, and I think we'll see more and more of this example in Indonesia as well. In Egypt, health spending data was successfully used to monitor and eventually redesign their social health insurance scheme. And a major factor that encouraged use of data there was that the analysis was really tailored to the priority question for Egypt at the time, which was how effective was their health insurance scheme in reducing out-of-pocket. And so technical experts tailored analysis to directly answer this question by comparing spending and enrollment in social health insurance with out-of-pocket health spending. And tailoring the analysis this way helped the Ministry of Health to clearly see that despite increased enrollment in social health insurance, out-of-pocket health spending was still increasing. And this led the Ministry of Health to look deeper into how effective the scheme was, for example, looking at the benefit package of services. Kenya is an example where tailored dissemination and effective packaging of data played a role. Health expenditure data in Kenya is widely disseminated, and they use language that is really tailored to each audience, and they have specific disseminations for government, for donors, and civil society. For civil society, the Ministry of Health used media to disseminate health spending results, and this led to civil society using the results to advocate for greater government commitment to buy ARVs through the introduction of a government budget line in the Ministry of Health budget.
Great, thank you, Krishma. I know you've been working on compiling lessons around using health spending data. Can you talk a little bit about what you've learned in that process?
Sure. The project has used its country experience to try to summarize how health financing data gets used in decision-making, and this will be published in an upcoming brief on HFG's website. I want to share some of those with you to answer your question. The first lesson, I think, is that policymakers have to make decisions in very complex environments and under time pressures. So political demands, interests from different stakeholder groups, decision-makers' own interests and preferences all play a part. And these factors may or may not align with what the data is showing them. And so having good quality data alone does not guarantee the use of data. And we must remember that decision makers are balancing many different factors when making decisions. Secondly, as we've heard today, countries must feel ownership of the data, or that they have some skin in the game in order to use it. Country ownership obviously isn't a new term, but it's key when it comes to using data for decision making. And in the context of decision making, we mean ownership in terms of the country defining itself what their policy challenge is, what their policy question is, the country being engaged throughout data production and analysis and dissemination. And after the data is produced, it means the country really having a say in what its priorities are and how it wants to move forward with the data that's been presented to them. A third lesson that we've seen across many countries is that packaging data effectively really goes a long way in ensuring it gets used. As we've said, and we heard from Lydia, decision makers are busy, and anything that really makes their life easier will help to get that data be used. And this includes making data widely and easily available, or better yet, bringing the data to the decision maker, responding to their preferences, and by this we mean how do the decision makers best absorb information? Do they prefer data visualizations? Do they prefer a more narrative report? Do they prefer a quantitative analysis? It's really important to understand that in order to know how to package data. And finally, using language and metrics that really resonate with the policymaker is important. So for example, when providing information about costs, it's important to understand whether you want to present data in terms of lives saved or in terms of dollar amounts, because those can have very different impacts. The last lesson we've learned is that using data to make decisions is really a behavior change, and this takes time. Producing data is easy, but it's important to invest time to build country ownership and work on these other factors we've seen if the goal is really use of data and not just production. Another observation is that building a culture of use is never wasted. So we found examples where data has been used by the country long after it was disseminated and in ways that were not expected. This can be challenging for funding organizations who want to show a more short-term or quick results, but it's important to remember that these investments can reap benefits in the longer term.
Thank you, Krishma. We appreciate sort of your third perspective, which is that of a more cross-country global view. And I think your examples are really important and emphasize the point that good quality data is important, but there are a lot of other influencing factors that determine whether data will be seen and then used, and we can't ignore those other factors when we're trying to get the data to be used. All right, so we would now like to open the floor for the audience to ask questions of our panelists. A number of questions have been streaming in, so thank you. If you have questions, please submit them through the Q&A window. So I'm going to start out with a few initial questions that came in. This first question is for both Lydia and NASA. So Lydia, maybe I'll have you answer it first. And the question gets back to the poll question we asked the audience at the beginning. From your perspective, whose job is it to ensure that data gets used for policy?
On not necessarily the technicians. I think the onus is on maybe those who are going to be impacted by the policy change, the implementers. So not necessarily the person producing the data, not necessarily the policymaker. I think there's a third group, the implementation agencies or whatever. They are probably the ones who need to use the data to push for policy change.
Okay, thank you. And NASA, I'll ask you the same question. From your perspective, whose job is it to ensure data gets used?
Monsieur Nassa, dans le pays, qui est responsable d'assurer l'utilisation des données pour la prise de décision?
Il faut dire que pour la prise de décision, ce sont les décideurs qui sont responsables en fait de l'utilisation des données. Donc les décideurs veillent à ce que les données soient de bonne qualité et à ce que les données soient utilisées. Merci.
Mr. Nassa said that in his opinion, decision makers are responsible for ensuring data gets used to ensure that the data is of quality as well.
Okay, thank you. Krishma, a question came in for you. Is there anything unique about financial data that makes it particularly challenging to translate into policy use?
That's a really interesting question. I think from HFG's experience, we often observe a perception among health planners that health financing data maybe isn't for them and that it's for accountants or economists or Ministry of Finance. And so sometimes there may be a tendency to underestimate the value of health financing data. Another factor here is that health financing data might be seen as jargony and complex. And I think it's for these reasons that it's important to use language that resonate with the decision maker and metrics that the health planners understand.
Thanks, Krishma. So this next question comes in from Regina Ombam from the National AIDS Control Council. She's asking, and this will be a question for NASA. She's asking, could you tell us who funds the health expenditure analysis, and if donor supported, how do you ensure culture of use in the long term?
Okay. Monsieur Nassa, on a une question. Qui finance l'analyse des dépenses de santé au Burkina? Et si c'est financé par les bailleurs, comment est-ce que vous assurez ce culture d'utilisation des données dans le long terme? Monsieur Nassa, vous nous entendez?
Ok. Ok, merci. Il faut dire que pour le financement de l'exercice, alors les premiers exercices, ce sont les bailleurs, hein, notamment avec l'Organisation mondiale de la santé qui finance. Mais à partir de... Oui, je vous entends. À partir de 2020, c'est l'État qui finance en fait l'exercice, donc le gouvernement. Donc chaque année, il y a une ligne budgétaire qui est consacrée pour la production et qui est réservé au suivi de l'utilisation des résultats des comptes.
So Mr. Nasser said that in the past, donors have supported the health accounts, including WHO, but more recently the government has committed funding to this. I think maybe another point to add that Nasser mentioned before is the Rapid Response Unit that's also supported by the government too.
So we have a question that's come in for Lydia from Alain Yao, and he's asking what types of technology, like IT technology, support the collection of health expenditure data? And we can also, if NASA has something to weigh in, we can ask him as well.
Okay. This data, the claims, a lot of it is electronic. So it's sitting in a Microsoft SQL database. And you have all the details of the medicines prescribed, the cost, at which site, for what age group and gender and diagnosis and all that. So it's electronic, easily analyzed with any software that can take big data.
Okay. So we have a question from Peter Vaz, and maybe this is something that any of the panelists could weigh in on, but he's interested to hear how politics comes into play in influencing decisions, despite the weight of evidence that could be provided to inform those decisions. Lydia, do you feel like you have any examples of politics coming into decisions?
I think politics can play a huge part. Even the launch of the health insurance, we had huge out-of-pocket expenditure in Ghana. We called it cash and carry, and it was because we were about to change governments that it became a promise to reduce out-of-pocket expenditure. And the new government, when they got power, knew they had to come up with a way of reducing out-of-pocket expenditure. And therefore, Ghana's national health insurance was born. And even some of the major policy changes around health in Ghana tend to be because there is about to be a change of government. Health is very important to the citizens, and so they begin to think of policy ways of, I don't know, to win the election. So timing, I think timing is crucial, and therefore politics plays a big part.
Monsieur Nassa, une question a été posée. Comment est-ce que la politique et les politiciens influencent les décisions, même quand l'évidence et les données montrent le contraire? Monsieur Nassa? Okay, unfortunately we can't hear Mr. Nassa, so maybe we can move to the next question.
Yeah. This is a question from Catherine Connor. She says, I heard that in Burkina the technicians interact, actually if we can't hear NASA, sorry, this is not a good question. We'll move to the next one. Sorry, they're streaming in quickly, so there's a question from Samson from UNFPA. He's asking, how is the private sector participating in the health space in the countries of the panelists? If the private sector is involved, what is the level of their involvement? Lydia, do you have any thoughts on?
Yeah, in Ghana's health insurance and health sector is very much has a private sector component. When we kicked off the health insurance, they decided to include private sector hospitals and clinics as well as the public sector. And then we have a large component which are faith-based healthcare providers. And even though it's a social health insurance run by the government, the private sector are heavily involved. And our tariffs and things are weighted. So the private sector providers get paid differently from the public sector because the public sector have government support. But all the data, financial data, comes from the private as well as the public sector. And that is where there's a challenge, because the private sector are not that keen to share their financial data.
Thank you, Lydia. Mr. Nasser, unfortunately we cannot hear him, but he did respond to that question, and he mentioned that for health spending, excuse me, they also analyze data, health spending data from the public and private sector, and they present the data in this way too, to encourage discussions of the private sector and to show what their role and contribution is in health spending.
This next question comes in from Eckhard Klanau. I'm sorry if I'm not pronouncing your name correctly, but the question is around human resources. He's saying human resources account for the largest portion of health expenditures, and he's recognizing that many countries face workforce shortages, and he's wondering if there's any experience using spending data to advocate for allocating resources to the health workforce.
Monsieur Nassa, la question était, les ressources humaines sont souvent la plus grande dépense pour le secteur santé. Est-ce que vous avez des exemples comment les pays ont utilisé les données des dépenses afin de changer la politique ou pour faire le plaidoyer pour un financement pour les ressources humaines?
Is Nasa on the line, or should I?
Go ahead, Lydia.
Okay. Because we are using claims data, and the claims are paid along the case mix, so there's an element of if you are overstaffed, you won't get enough money based on the work you do to pay your staff. So, and if you don't have enough staff, obviously quality suffers and patients move away from your facility. So I do believe, although it's not quite the same as financial data, but the payment mechanisms are beginning to affect HR to some extent. Thank you.
Thanks, Lydia. I think one example that I've seen is, for example, in Haiti, the health expenditure results showed a high proportion for human resources, especially for government spending. And so this kind of led to a more detailed study of looking at their human resources and how they're being allocated and whether improvements could be made.
I'm going to jump back in. This has been a really rich discussion. Unfortunately, questions keep streaming in, and we're out of time for today. I want to thank our three panelists for joining and sharing their wealth of experience. I also want to thank you, our audience members, for tuning in and being so engaged. If you're looking for additional resources, you can check out these documents on our HFG website. Just a short logistical note, when the webinar ends, you will see a pop-up window asking you to provide answers to a few short questions to provide feedback on the webinar. We ask that you please submit your answers to these questions, as it will just help us inform future webinars. As I mentioned, this was the first of a series of 3 webinars that we're hosting around health resource tracking and health expenditure data topics. So stay tuned for the 2 future webinars that we'll be conducting. The next one will focus on how countries choose which resource tracking methodology is right for them. Oftentimes, they're overwhelmed with so many options and they don't know how to pick which one best suits their needs. And the third webinar will look into how countries can streamline the health data collection production process. So stay tuned for more details, and we just want to thank you again. Goodbye.
Goodbye.